Good afternoon, everybody. Welcome to the Innovation Exchange Pulmonary Rehab event today called Pulmonary Rehab, What is the New Normal? My name's Mike Kenny, and it's my pleasure to introduce our chair shortly. Before I do, just some housekeeping. You'll notice that everybody that's joined today has been joined on mute, so that's great. There is going to be a Q&A box. You should be able to see a Q&A box. So as you hear the presentations today, please do remember to put your questions into the Q&A box, and then Professor Roberts, who's our chair for today, will be able to work through those when we have the Q&A at the end of the speaker sessions today. So thanks again for your time and attendance, and I'd like to introduce Professor Roberts to chair the meeting today.
Brilliant, thanks so much, Mike. One mic to another mic. Really nice to be here. Obviously, the big C has caused all kinds of troubles to us, but one of the advantages is that it's really enabled people to come together in ways we might not have done before. And we've got nearly 400 people registered for this who I don't think would have registered for this kind of thing if it was a travel to somewhere distant in the country. So that's really good stuff. Just two very quick things. Firstly, and this applies to the speakers as well, if you're not about to speak or speaking, let's turn your video off so we only have the video on of the person who's speaking, and I'll do the same thing. And the second thing is, can I just ask you to try to keep the time, because we've got quite a tight time schedule. However, great privilege and pleasure to introduce my colleague, Professor Andrew Menzies Gow, who is the National Clinical Director for Respiratory and is going to set the scene for us now. Thanks, Andrew. Go for it.
Mike, thank you. My absolute pleasure to be here. It's been a very challenging year for everyone in respiratory medicine for lots of different reasons. I just want to spend a couple of seconds almost reflecting where we were at the beginning of the year, and I'm really pleased that we're talking about pulmonary rehabilitation. It's key to our ambitions within the respiratory long-term plan. We understand that pulmonary rehab is very clinically and cost-effective, and is one of the most important things that we can do, particularly for people with COPD and other chronic respiratory conditions. And we had a planned big investment and a big expansion this year. Then obviously coronavirus came and knocked us all sideways, and a personal thank you to all of you that would have been working very hard to look after people with COVID and other acute and chronic respiratory conditions throughout the whole of this year. I think now is the time for us to look ahead and to plan. We've had the first vaccinations yesterday. Obviously the mass vaccination program will take months, but we will be getting back to some semblance of normal next year. And everyone with both acute and chronic respiratory conditions beyond COVID continues to need our help. And actually, as challenging as this year has been, it does give us the opportunity to try and do things differently. And COVID has shone a light on the fact that health inequalities are such a big issue within respiratory conditions, and that is incredibly true for COPD and all other chronic respiratory conditions. So we need to do better around that. And as you're sharing all your innovative ideas today, I think that's great. My one word of caution, which is easy for me to say but hardest to fix, is we always need to remember around digital inequalities to make sure that we not, through our enthusiasm to grasp the new, disadvantaging anyone else. But I know that won't happen, because I know you're all passionate about improving the care for people with COPD and who require other forms of pulmonary rehab. And then obviously I can't not talk about coronavirus without thinking about post-COVID syndrome and recognizing that additional burden for helping to rehabilitate people with very disabling symptoms after exposure to coronavirus, as well as everyone else that needs our input. So thank you for all the effort. I know there's a great group of speakers here that are going to be very inspiring for next year. I know it's been an incredibly tough year for all of us, but 21 is an opportunity for us to refresh and reset and really bring in things like pulmonary rehab, which are so clinically and cost effective, and we should be striving to make sure that everyone who needs it gets it in a timely fashion. And whether that's face-to-face, whether that's virtual, whether that's blended, I think is all about us personalising the care for the person in front of us. So I'm going to stop there to make sure you keep the time. Wish you a really enjoyable session, and I'll look forward to hearing about it soon. Thanks very much.
Brilliant. Thanks, Andrew. That's fantastic. And I really do appreciate you coming. I know you've got to rush off and do something else now, so please do that with our blessing. But thanks so much for spending the time with us today. That's brilliant. Great. So we need to crack on with the agenda. I didn't have a chance to introduce myself. Not that really matters, but I'm an integrated respiratory physician down in Essex, Managing Director of UCLPartners, which is part of the Academic Health Science Network, which are putting on this event and hosting it today, and the Senior Clinical Director of the National Asthma and COPD Audit Programme, which I'm sure many of you will be familiar with. It includes pulmonary rehab, and we'll talk more about that in a moment or two. So, great pleasure now to introduce the first of our speakers, who's Dr. Stewart Berry from East Lancashire, who's going to talk about his views and his innovations in this space. So over to you, and thanks so much for. And you're on mute at the moment, Stewart. If you can just come off mute. It's that rookie error that we all make.
And can you see my slides at all? Am I managing to successfully share my slides or not?
Yeah. Yes, but could you put it in presentation view, Stewart?
Yeah, sorry. View.
You have a little resume slideshow button popped up.
Ah, yes, thank you. Okay, so can you see the starter slide there?
We can.
Yes.
Great, okay. So just to introduce myself, my name's Stewart Berry. I'm a GP at Redeployment Healthcare in Nelson in East Lancashire. And I'm going to give you an overview of our experience of using the MyCOPD tool with our patients since 2017. I think it's important to put this in the context of back in 2017, the MyCOPD online platform was one of the few platforms that was out there, which was a means of offering video-based educational content to patients. At the time, if we wanted to offer videos to our patients, we would have basically had the choice of creating our own videos, which would have been quite costly and time-consuming, or buying them in from someone else. So back in 2017, we had the option of using this tool, the MyCOPD online platform. The main selling points were that it was allowing us to give patients access to high quality videos, which were going to deliver the educational content that we were after, alongside a pulmonary rehab course, which had been shown to be as effective as traditional face-to-face pulmonary rehab. So it was going to enable us to reach some of those patients that were not being reached by the traditional bring the patient along to a face-to-face rehab session. We were mindful of the fact that although we were offering pulmonary rehab to all our patients, there was a significant proportion of patients that just weren't taking up that offer. So we were keen to explore what other options we had to get more patients benefiting from pulmonary rehab. Now, on the MyCOPD platform, there's quite a nice dashboard that the patient can navigate, and they can find themselves looking at educational content on a range of topics, such as things like smoking cessation, inhaler technique, vaccinations, as well as some of the really useful stuff like relaxation techniques. The videos are of a high quality and the user interface was good, so everything looked great. The other point to mention was that the manufacturers of the MyCOPD platform weren't just thinking about it being used for patient education. They also had a mind of creating some sort of a clinician-based dashboard that would enable the clinical team to have some sort of a bird's eye view in order to spot which patients were at risk of deterioration, with the intention that clinicians could step in and offer some support. Now, this was a good idea. However, these were features that primary care wasn't necessarily looking for. And it could be argued that possibly by making these features available, it may have overcomplicated the user experience a little bit. So that may have got in the way of the patient experience and may explain some of the factors that led to patients using it less than we were expecting they would do. Back in 2017, Pennine Lancashire was adopting a blended approach to the educational aspects of COPD care. All patients were offered the traditional routes to pulmonary rehab, as well as being offered access to the digital tools like MyCOPD. We also made available to practice staff some printed resources, so some traditional print media, so that we could reach out to those patients who were not digital. And the idea was to make them aware of the other things that are available. Sorry, my slides are jumping around. Sorry, can you hear me?
Yeah, we can.
I'm trying to make it go back to the full slide view. Is that the full slide view?
It is, yeah.
Okay, so there we go. So the way that we were rolling this out to patients was that the MyCOPD online platform was offered to patients at the time of them having their annual nurse-led COPD review. We also took the opportunity of mentioning it at every chance in order to make as many patients as possible aware of this. Within East Lancashire, we've got systems that we can use to do targeted messaging direct to patients using SMS text messages. We also sent out letters to patients. So we were quite conclusive. We were quite all-embracing in our techniques we used to try and make sure everyone knew about this. But what we found was that a lot of patients were turning down the option. When a clinician is using the MyCOPD platform, the clinician logs onto a web page and they use that dashboard in order to set up a patient on the system. You only need the NHS number and the patient's email address, and then the dashboard sends the patient a link with the password that they use to log on to the system. So the actual process from a clinician is quite straightforward. The weak link potentially in the system is that it requires the patient to be quite competent at using email, and where the system kind of didn't work quite as well was when the patient didn't understand how to reset their password. From the clinician perspective, when you're looking at the dashboard, you see a list of patients down one side, and you also see a list of the most recent CAT score, as well as an indication as to when the patient last logged onto the system and when they last gave some symptom assessment score. So we're able to tell quite easily how frequently patients are actually making use of this system. My practice has 12,000 patients on the list. We have 215 patients with COPD. Of those 215 patients, despite all the effort that we put into onboarding patients, I was only able to persuade 44 patients to take up the offer of the MyCOPD license. So that equates to 20% of our COPD patients. Data, I took a look at the dashboard yesterday. We have 15 patients. So of the 44 patients that were given the license, we have 15 patients who have used it this year, and I have 6 patients who have used it in the past month. So a couple of observations. Digital activation is a lot more nuanced than just dividing patients into being non-digital or digital. Patients and staff have a wide range of digital skills. We will all know members of staff or members of our family who are really, really good at using digital technology and the internet and online shopping and taking part in social media and all that. But then we will also know other people, friends and family, patients who struggle with that. Maybe they're just dipping their toe into the digital pool, and maybe they do some things but can't do others, or they're able to do shopping, but then something happens and they really struggle to make a password work or use an app after it being updated. Back in 2019, I was looking at the dashboard and I was looking at all the people I'd offered licenses to and where the patient wasn't using them. So I contacted each patient one by one and talked through with them what the problems were they were having. And by far the single biggest problem that I came across was patients having problems with the password. Some of them had registered it using an email address they weren't familiar with. Other people had registered their account using a housemate's or a relative's email address, which meant that when it came to resetting the password, they weren't able to do that. So one conclusion is that the level of support that is offered to a patient in order to help them to use the digital platform is a critical factor when it comes to reaching those less digitally proficient patients. Another observation is the quality of device and the quality of access to the internet is so important for patients. The patient's experience of an online pulmonary rehab tool will be dependent on what devices they use to watch the content. So most of us, hopefully, have experienced the usefulness of being able to stream a video from a mobile phone onto a big screen, like a big TV set. If a patient was trying to watch a pulmonary rehab video just on a small mobile phone screen, you can imagine that that's going to be a much less good experience than the experience they would have if they were beaming this to a big TV in the corner of their lounge. We do have support available to our patients. So because we were aware that we were missing a large chunk of our patients, a big proportion of our patients were not taking up the digital offer, we put things in place. So we were working closely with the Council for Voluntary Services. We set up drop-in training sessions and support. Unfortunately, we found that these weren't being taken up by the patients. So there's something about the patients who are turning down the digital offer are turning down the digital offer for a variety of reasons, and we don't necessarily understand those reasons properly yet. So there are patients who financially could afford to be using this digital technology. They could afford the internet and decent devices, but they're choosing not to. We also have patients where cost is a real issue and they just can't afford to have a good high quality broadband connection or the latest devices. So it's December 2020. One of the things that I frequently go on about is the fact that we currently do not have a nationally agreed way of coding the degree of digital activation that a patient has. So we don't have an easy way of coding to the patient record whether the patient can order their medication online, or if they can book an appointment online, or if they could complete a digital triage form. Frequently nowadays, we have patients who present to the GP with a rash, and the digitally enabled ones, now they're really straight on it, taking photos and sending them into the practice. We don't have an easy way of flagging up which are the COPD patients that are joining in the digital journey and which are the ones that are being left behind. We don't know what percentage of COPD patients have broadband at home. And we don't know what percentage of COPD patients have the ability, skills, and capability to take part in video consultations. And I think that is a shame in 2020. There are many different barriers to the adoption of digital tools by patients. These include cost, knowledge, and skills, as well as availability of digital infrastructure. This is particularly a problem in rural communities where there just may not be decent broadband or indeed a decent mobile phone network. So in summary, My COPD online tool does offer ready-made off-the-peg video guides which are beneficial, but really only to those patients that can access them. Part of the problem that patients have in accessing this system is that it requires them to remember a password, and some patients are just not very good at managing passwords. The uptake was much less than anticipated, although it has offered us some valuable insight into the low levels of digital activation of this patient group. Nowadays, 2020, there are a range of similar resources, not the same, but similar. So I'm thinking about educational videos and websites that are available and that are not situated behind paywalls. And what this means is that expert patients and clinicians can share these resources with other patients using tools like social media. And it means that this information is much more freely available, and we're much more likely for patients to come across these things themselves. I've included here a selection of websites that I use with my patients. The My Lungs, My Life website is very good. I've also flagging up here the Breathe program from the Liverpool Heart and Lung team. Bite Breathe is an excellent resource for inhaler techniques. British Lung Foundation does some really great stuff, and you'll all be familiar, I would have thought, with the NHS 1U website. And then within that, there are some nuggets such as the Active 10 app, which is a free app that patients can download that encourages them to step up their level of exercise. So there are a range of things that patients can use that are maybe it's a different funding model to the My COPD platform. Thank you.
Brilliant. Thanks ever so much, Stuart, for that, starting us off really well and highlighting some of the huge challenges that there are in the system. Thanks for keeping to time as well. Just to remind everybody out there on this call, please do add in questions that you've got into your chat. Please also add in any pointers. You may have solved some of these problems. You may know the answers to some of the questions that are being raised. If you've got good practice or anything that you'd like to share with other people, that's part of the value of this kind of session. So please don't hesitate to put your ideas and concepts into this. We're going to have questions and answers at the end when all 4 presentations have been completed. So please put your questions in, and then I'll try and deal them out to the appropriate people. And if you think you have a question for a particular presenter, then please put that into the chat so it's clear who you'd like the question directing to. Otherwise, it's down to me, and I have no idea what I'm going to do with that. So Stuart, thanks very much indeed for that. And now we've had to have a slight change to our running order. So we've now got...
Sorry, Mike, to interrupt, but I think we're great to go. We should be okay to go to Mukesh now.
Oh, okay, fine. In that case then, thank you for the correction. So now we've got Claire Stamp, Mukesh Singh and Farhan Amin, who are from Staffordshire, who are going to talk about their innovation. Over to you guys. Thank you.
Thanks. Mukesh, if you want to just give us a try at speaking. Sorry, everybody, we've had some technical issues with Mukesh in the background. Can you speak to us now, Mukesh? No, it looks, sorry everybody, it looks like we're still having those technical difficulties. If you could just bear with us 1 second.
Part of the joy of webinars, of course, is the technology doesn't always just phase the patients. It can phase even the most technically literate people that there are on the planet. Whilst we're having this little interregnum, do you think you could just put in a few questions into the chat, or any observations you've got so far? Anything to do with the new reality around pulmonary rehab? Just pop things into the chat. Use the time productively. Thank you. Okay, team, I'm just thinking how long we can stick with this problem and whether we should move on to Rebecca's presentation. Perhaps you could let me know in the next few seconds whether you think we've got a solution in hand or whether we ought to move on.
Yeah, if you just bear with us for just a couple more seconds and I'll just update you. Sorry, everybody. Okay, so we are struggling to get Mukesh on the session. I'm sorry, it doesn't look like we're going to be able to solve it from his end at the moment. Our next speaker also hasn't yet joined us as it's not time for her slot. So I'm just wondering if we could take any questions there may be for Stewart at this point and go with that as an approach just for a few minutes while we try and fill the in the background.
Well, can I just suggest I do my presentation, because I think the problem otherwise is going to be we're not going to have time for the other presentations. We're going to run out of time. So shall I do that and go forward with that? And
let's jump.
You will have to let me know when you have got the other presenters available, okay? But I will go with that. So if I could have the share screen facility, is that available to me?
Yep, you should have that now.
I've got, okay, yeah, I've got it now. That's fine. And I'm just going to put in the presentation, hopefully. And can everybody see that now? And I'll just hide the hide presenter view, and that should be, is that okay now? You can see that?
Yeah,
fine.
that's fine.
Okay, great. Well, apologies for the technical problems some of the other speakers have had. So you've got me early on, but may not be a bad thing. So what I'm going to do is talk to you a little bit about the National Asthma and COPD Audit Programme, and particularly with emphasis on the pulmonary rehabilitation. And I think the points I want to make really are that whatever the system is, whether it's the old system or the new system, what we need to be committed to is ensuring that we're giving good care to our patients. And the only way we really know that is if we're measuring what we're doing, seeing the results from that, and then reflecting on how we can improve the system and our own services based on the data and the evidence, rather than making assumptions. And the National Pulmonary Rehab Audit gives us that opportunity to enter those data and to have a look at what's going on. So let's have a look and see what we can learn from the system. So just to remind you first that the pulmonary rehab element is part of a wider national audit programme. It involves primary care data collection just in Wales, but there's a lot of learning from that, and that includes pulmonary rehab data, so who's been referred, who should have been referred and why not, and those kind of issues, and around secondary care, acute hospital care of patients admitted with COPD, with adult asthma, and children and young persons asthma as well. So that's quite a wide range. There's a quality improvement programme that runs alongside of all of this, and I'm going to touch on that in a moment. And then we've got the star of the show, of course, the pulmonary rehabilitation audit as well. So just a bit of context to that. It runs currently in England, Scotland and Wales. I know most of you will be more interested in what's going on in England, and so I'll focus on that in a moment. Scotland's dropping out of national audit with the UK as a whole, with England and Wales. That's a Scottish government political decision from March, so they will no longer be taking part in any national audits. Doing their own thing instead. But if we look at the number of patient records, 27,000 we've got entered into the database, which makes it the biggest clinically collected audit for pulmonary rehab in the world. and certainly by far the biggest collection of data we've ever had for England and Wales. High take-up of the audit participation by PR services, but again, one of the problems we've got is that there is no national record or register of PR services anywhere. So one of the learning for us was trying to find all these services by using networks, and now the British Lung Foundation have a tracker website to try to track down all the services as they develop. And as you know, often the contracts are relatively short term, so the service may be contracted for 1, 2 or 3 years, and then the contract moves to someone else and that service folds and another provider will take on the contract, and that can be a bit of a challenge. In England, over 90% of the services, however, have submitted data for the pulmonary rehab report. So one of the points I wanted to make is that with this new kind of virtual first frontage for pulmonary rehab, or a mixed blended approach, whatever it is that's determined to be the right way forward, there's 2 points I wanted to make. One is that the old system, which often people hark back to and say, well, it's no good unless we've got full face-to-face, didn't always deliver everything that it should have delivered. So this, I would like you to think about, is an opportunity to make things actually better than they were before, rather than just say, we've got to go back to the way it was. Because the way it was wasn't necessarily great for every patient in every service. But the second point I want to make, and that really contradicts in some ways perhaps what I've just said, is that the old service did deliver some things really, really well. And what we must make sure is that we don't throw that out and lose that in any new blended or virtual type system. So here's some of the headline data from the last PR report, and interesting things to see. So we know that a national standard is that people should be started on the PR program within 90 days of being of the referral letter being received, but actually it's only 58%. So this offers an opportunity maybe to do something better about that. And in fact, those waiting times have got a lot worse, as you can imagine, during the COVID period. And then what about practice walk tests? So you must have a practice walk test, because if you don't have a practice walk test, it's extremely difficult to know that any subsequent walks are based upon a proper baseline, because as you probably appreciate, after the first walk, the second walk is usually better, just because the patient understands more about what is expected of them. So unless you've got a baseline test, which is after a practice walk, so you've got a practice walk, then a baseline test, you're going to get an improvement almost certainly, even if you didn't go through a pulmonary rehab program. So we should be doing that as a standard, but less than half the services routinely do that for their patients, and that's really poor. That is going to be a challenge for a virtual or a blended approach, but something that we need to be cognizant of. And then discharge assessments in 70% of people, it's not bad, but it should be higher than that. And in terms of the outcomes of PR, 60% have an improvement in exercise, which is great. That's very similar to the randomized trials. That's very good. But given that over half the patients haven't had a practice walk, that may just simply be a reflection of people being better and more familiar with doing the walks. And that's worrying. 58% get an improvement in their quality of life scores, which again is similar to the randomized control trials. There's going to be another report or series of reports published very soon, in fact tomorrow, but I'm not allowed to tell you anything much about those reports. It's just the way the system operates and the confidentiality in it. But these are the reports coming through, a whole range of reports that will be available tomorrow from the website. You can download them all as PDF, clinical data, methodological, patient-specific report, organizational data, and then local reports for each site. So a whole load of stuff that's going to come to a PDF site near you. Now, I did mention also the quality improvement, and I think that's really important too. So we have a number of run charts that we publish for the PR audit, and run charts basically tell you about what your performance is like on pretty much a daily basis, compared with a quality standard that we might have, an improvement aim, and benchmarked against what other units across the country are doing, so you can see. And these are the various areas that we measure in run charts. And what this allows you to do is to see your own performance, the quality of your service. The charts are updated every 15 minutes. So as long as you're putting the data in regularly, you're going to see up-to-date understanding about how good your service is doing. And what also means is that if you make an intervention at some stage, then you can see pretty quickly whether the intervention's working or not. You don't have to do a before and after study a year after you've made the intervention and find that a year later nothing you've done has made any difference. You'll know pretty soon, within a few days, a few weeks, a month or two, by looking at the run chart whether things have changed. This is a national run chart, just to give you an idea of what we're talking about. So you can see along the bottom the dates and on the vertical axis the waiting times, the metric we're measuring, the waiting times for people to be seen for pulmonary rehab after they've been admitted with an acute exacerbation. And it's a pretty sorry story, but one I think we're all familiar with as a result of what's been happening with COVID. But even pre-COVID, you can see that the wait times were going up. So more people were being referred, we think, but services weren't being increased in their capacity. Now, obviously, what we measure in the audit is important, because if you're not measuring the right things, you're not going to see them. So for most non-face-to-face audits or PR systems or blended PR systems, we're still going to need to record all the same sort of things we do for face-to-face PR, because PR is based upon those interventions. That's what the evidence tells us we need to do. But these are some of the questions that we've added into the audit to try to capture the diversity of delivery mechanisms which are coming through. And one of the things you might like to do as part of the chat is to make some suggestions as what you think the audit should be collecting in terms of the new form of audit, the non-face-to-face or the blended type of audit, PR program that we'll be rolling out soon. So if there are things you think we should be capturing that reflect the new type of pulmonary rehab programs, the non-face-to-face pulmonary rehab, please make some suggestions in the chat that we can think about including in the audit going forward. So to summarize, I think traditional pulmonary rehab didn't deliver everything perfectly. There are things that we can improve on, and maybe this new system might help us to do that. But also, let's not forget that pulmonary rehab is based upon an evidence of things which are important to include if we're going to see effects. And some of the things we've done in the past have definitely been very, very effective in terms of outcomes for patients. And whatever we do, we mustn't lose those things. But finally, my plea is that unless we record the process and outcomes of the patient through something like the national audit, we'll never know whether the new systems we put in place are making things better or making things worse for our patients. So please do take part in that. If you want any more information or want to get in touch with us, we'd be delighted to hear you. Just use any of those means of getting in touch. Thank you so much. So all I've got to do now is try and stop sharing.
Thanks, Mike. Rebecca should be ready to go.
Okay, hello. That's good. Go for it, Rebecca.
Hello. Phew, I'm here. I don't know if you can see me.
Just need to hopefully you can see the slides.
I can see the slides. Hopefully everybody else is good.
Yep.
Can you all hear me okay? Lovely stuff.
Yeah, we can hear you. Perfect.
Fabulous. So my name's Becky. I'm a respiratory physio in Nottinghamshire, covering a smallish patch, which is Nottingham North and East. Historically, Nottingham has been split up into quite small CCGs, which amalgamated at the beginning of the year. So what we saw back in March was that following the national guidance, we stopped our rehab classes. We contacted our patients and explained the situation. To be completely honest, we had a significant number of patients who had kind of started dropping out and saying that they didn't want to attend because of what they were seeing in the media and the risk factors involved. But when we got that call to stop, we stopped rehab. We contacted all of those patients to say, this is the situation, we will contact you when we know more. We had significant staff redeployment. I went and swabbed in care homes. Another colleague was redeployed into an inpatient rehab unit, and we were tasked with upskilling the community teams, the broader therapy teams, to be more confident and competent dealing with this wave of post-COVID respiratory patients that were supposed to be coming out of hospital. All the time in the back of our head, we were really worried. We knew that we had this significant group of vulnerable patients who were falling into the high risk or extremely high risk group for COVID. Most of those were shielding, and suddenly their activity levels were significantly reduced, and that deconditioning was going to become a massive problem quite quickly. Do you want to scroll through to the third slide for me? Lovely. So we were in a situation where we had always been very separate teams. We had worked very independently. We had the Rushcliffe team who saw Rushcliffe patients, and we had Nottingham North and East, which saw the patients in our area. But we were all having the same problem. We all had the same vision, that we had the same similar patients who all needed support, and we needed to provide that in a brand new way. And that, alongside the amalgamation of the CCGs, really facilitated us to work together in a much more cohesive manner, share ideas, share the problem, and share the solution as well. It meant that we could work together and create a new process that would work across the patch, taking into account the fact that we come from very different services that are set up and present in a very different way. It's also worth mentioning that historically, both Nottingham North and East and Rushcliffe have only ever provided face-to-face pulmonary rehab. We have never been a service that provided at-home pulmonary rehab or any kind of virtual service. We could scroll through to slide 4, and if you just flick up all the fancy bits, that would be lovely. So we broke down the service into its core components and thought about, well, what do we need to deal with to provide this brand new service? So we first and foremost looked at safety. We looked at how we were going to assess both subjective and objectively. We thought a little bit about our outcome measures. We thought about treatment and what treatments we would provide and how we could provide them. So looking at our exercise programs and looking at how we would provide an education program too. And finally, we kind of looked a little bit about how we were going to evaluate what we were doing and whether what we were doing was working. We looked at what could be utilised from what we already had. So face-to-face programs were really well established. Both teams were using System 1 for documentation, and we had lots of templates and things on there. So we looked at those, and for the most part, they were still very relevant. We went on to look at what resources we had available. So we looked at what digital resources were available for providing pulmonary rehab. We focused on the MyCOPD app and Space for COPD. And then we looked at what paper resources were going to be suitable as well, being very aware that the vast majority of our patients do not have significant IT literacy. And we went for, in the end, we went for the British Lung Foundation exercise handbook, and we used the Hare and Bromfield education booklet as well. And both of those were recommended through the British Thoracic Society. So we had a little look at the resources and what were available, and we also looked at our staffing. What staff did we have available within our current teams? What staff had been redeployed? And what staff were currently available in other teams because of business continuity and weren't currently busy in their usual active roles? So the way we tackled seeing patients, if you could just slide on to slide 5. We looked at the recruitment process first of all. we started with an initial screening telephone call, and that entailed ringing the patients, having a little chat about how they were getting on. Were they coping all right at home? Were there any urgent issues that needed to be addressed? Had they received their shielding letter? Because along with that went the access to a lot of support if they were shielding. Were they coping? Were they managing to get other medications as normal? Were they managing to get their food? Were they managing to get the relevant support that they needed to meet their immediate needs? How were they dealing with being shielded both physically and mentally? Were they in a place where they were ready to start pulmonary rehab? And once we got through that initial screening, we kind of started asking about comorbidities and their respiratory condition and how they were getting on from that point of view. And finally, if we got through all of that, we would ask them about their IT literacy. So what could they manage at the moment? Did they have access to the internet? If they did have access to the internet, what could they manage? Did they have an email address? Could they log on to do things like online shopping? Were they answering emails? Could they open an attachment to an email? Just to give us a real sense of where they were at, and that helped us to direct them towards the most relevant resource to manage their situation and to set them up on pulmonary rehab. Once we completed that initial screening, then we completed a telephone assessment, went through their objective and their subjective history. We posted out the questionnaires, and for us it was really important that we tried to use as many of those outcome measures that we were using pre-COVID during that time, because then we could have a comparison between how we were doing and compared with our normal rehab. So for us, we used the COPD assessment test, we used the chronic respiratory disease questionnaire, we used the hospital anxiety and depression scale, and we used the link as well. So we posted all of those out to patients and they completed those at home. And then we would carry out a home visit, and that predominantly was carried out by either an assistant practitioner or a physio. And during that visit, we would do a number of things. First and foremost, we would check that their environment was safe, make sure there was no particular clutter, make sure that it was an environment where they could safely exercise, check that the patient was safe mobilising, make sure there was no immediate issues that would contraindicate an at-home pulmonary rehab programme. And finally, we would complete a set of OBS and a 1-minute sit to stand test, so that we had a physical outcome measure and that we checked that their blood pressure and their oxygen levels were within an acceptable range to exercise. Once that had been completed, we'd set them up on a programme. Predominantly, patients opted for the paper programme, with some going for space for COPD. And I will be completely honest, not that many went for the My COPD app. The main issue with the app was that people struggled to download it, which sounds really basic and a really easy thing to overcome, but that was the main issue. I wonder whether some of that was because they were patients who were perhaps less computer confident. So if people were very confident, we tended to direct them towards space a little bit more, but we didn't have that many people use the My COPD app. And once they were set up on their programme, they would have ongoing regular telephone support from a respiratory physio. And during those telephone calls, we would support with exercise, making sure that they were exercising at a sufficient level, that they were pushing themselves but not pushing themselves too hard, so finding that right balance. We talked through the education programme as well. And then finally, we'd finish with a post-assessment sit-to-stand test and repeating the questionnaires, very much in the same way we would when we were running face-to-face classes and clinics. And again, the questionnaires tended to be posted out to the patients for them to complete, and then we'd pick them up when we went and did that sit-to-stand test. And to complete the programme, if they needed support from the respiratory nurse or from other services, then we would signpost on to them. So data, I'm not going to focus on the numbers too much because we haven't got time. So we had, back in April, we had 78 patients on the Rushcliffe waiting list and 150 waiting in Nottingham North and East. In Nottingham North and East, our waiting list is always quite significant. So we always have about 100 on the waiting list. And we are seeing pretty much all of those within the 13-week wait ordinarily. But the waiting list crept up because patients were reluctant to come for assessments back in sort of end of February, beginning of March. We had the patients who were on the programmes that went back onto those waiting lists when we stopped the programme as well. So that's why our numbers are a bit higher than normal. Between sort of April, May, June and end of November, Rushcliffe have assessed 78 and NNE have assessed 116. And you can see there that we've started 58 in Rushcliffe and 83 in Nottingham North and East. And those numbers of people who have been accepted and have started are probably quite similar to what we would see in a face-to-face group. And the same goes that we haven't got the data yet for completion rates, but I would say that they're probably similar or even possibly a little bit better compared with our face-to-face groups. And interestingly, the patients who perhaps have failed to attend pulmonary rehab in the past, they've maybe come for an initial assessment and then not started the course or not completed the course because they've just DNA'd. Anecdotally, I think we've had far more success getting them through the programme. And I think that's been particularly with the patients who struggle with anxiety and particularly around being in a group environment. So if we just move on a little bit to feedback now from the patients, it was overwhelmingly positive. Patients really appreciated having that support during what was a really, really scary time and still is. They're really grateful for that regular telephone contact. They really appreciate that somebody is ringing in and saying, how are you doing? Particularly that hasn't just been about how your exercise is, it's been a well-being check from a much broader sense. So we've asked about their mental health, we've asked about their physical health, we've signposted a great deal through to the IAT service, we've signposted back to the GP to say you need to go and get that investigated, because patients are still reluctant to go and see their GP about issues because they don't want to be a nuisance and they know that everybody's really busy, but really encouraging and facilitating that with patients has really been quite positive. Patients have found that their IT confidence has really grown. They feel far more capable and enthused about exercising at home than perhaps they would have done with the group programs. So here's a little bit of direct. If we go on to slide 8, it just gives some direct feedback that we've had from patients. So we can see there that we've had an impact on physical outcome measures. So I can now walk to the local shops, which I couldn't do before. The program's been informative, enjoyable, and completion of the app daily motivated me to keep going. They've enjoyed the exercise videos on Space for COPD. They've really enjoyed the fact that they can keep going back to those even once they've been discharged from the programme. And patients have felt a lot less alone. Have I still got you or have I lost you?
Still here.
Excellent. My screen's just changed. Phew. So we're just moving on to slide 9 now. So staff feedback has been, it's been an extremely positive experience to be involved in a team that has embraced different ways of working and adopted new skill sets. It wouldn't have been possible without the support and flexibility of the administration team, who have willingly agreed to assist the change process in any way they can. And that goes as well for the assistant practitioners who certainly in Nottingham North and East, had never worked within a respiratory service before. Never mind running a pulmonary rehab program, and never mind running an at-home pulmonary rehab program that was brand new to all of us. But they very much stepped up to the plate and said, right, how can we support this? How can we help these patients? And really facilitated a patient-led, patient-centered service, which is in a lot of ways a little bit different to how we ran pulmonary rehab in the past, if I'm completely honest. Historically, pulmonary rehab has been very much, these are the exercises we provide, and they've been tweaked a little bit, and this is the education program we provide. But above and beyond that, it's been, well, you've had to be referred into the at-home respiratory service. It's really facilitated a lot of collaborative working as well. It's encouraged us to work far more across a wider Nottinghamshire team, providing a south-wide approach. We are working far more with our peers. We are integrating far more with not just the community services, but also the acute services as well. It's really facilitated that. And that working well together has supported things like winter preparedness as well. So moving forwards, what we're hoping to look at is providing some kind of virtual rehab classes, which will be an ICS-wide approach, so it will cover all of South Notts, so that those patients can be accessing that irrespective of where they live, and starting to rethink how we're going to provide face-to-face assessments and face-to-face classes in the future. Thank you very much for listening. Has anybody got any questions?
Yeah, we've got a few questions. So I think perhaps if Stewart and Rebecca could both come up on screen, if you're able to put your video cameras on, that would be really good.
Hi.
Hi. I am
Great.
not entirely sure how to put my camera on.
There should be an icon on the right-hand side with a little camera picture in green, and if you click on that, it should bring you on.
There's like a red arrow to the
a red
side.
arrow.
And then underneath the red arrow, there's a microphone, and then there's the camera picture.
According to
click it anyway and see what happens. Just click on it and see what happens.
There you go. That's me. Clicked it. Can you see me?
No.
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 We can hear
you. You can hear me. That's probably.
We can hear you.
We've got a box now. Maybe you're coming.
Oh, maybe.
Whilst we're waiting, can I just check with the organisers? My understanding is that the talk from Staffordshire is not going to be possible for technical reasons to go through. But just to reassure everybody that we'll send out the slides for that talk and the other talks you've heard today. So again, in the questions, unfortunately, after I finished my talk, I got a question to say, could you please hide your control panel, which I apologize if that was an issue. One of the things, the learning path from this is that this is a new software platform for all of the presenters, and maybe next time we'll have a bit more time to familiarize ourselves with the technical side of things before we get going. Anyway, you've put in a few questions, and I'd like to try and field some of those to our presenters today. So firstly, Stewart, if I could start with you. You've highlighted a lot of the issues and the problems that there are with the uptake of COPD. Do you see any solutions? What can we do? Or do you think it's the wrong app altogether and we should just dump My COPD and go for something completely different?
I think so. There's two separate. I'd separate out the things. So one aspect of this is digital exclusion. So just like we know there's a strong correlation between poverty and poor health, and there's a strong correlation as well between lack of digital access and poor health. So one of the issues is how do we try and ensure we've got better access for all our patients to digital technology. There are some schemes that are going on in Lancashire, for example, that I know about. So there are some schemes whereby So there's one scheme in particular where they provide families with a Raspberry Pi computer along with some training for the child in that household so that they understand how to use the computer. And then that leads to the whole family understanding more about what you can do with the computer and digital technology. So there's almost a need, I feel, for us to have similar schemes for our older population as well. So there's almost a need to try experimenting with some sort of try before you buy type schemes, or schemes where you give the patient access to the internet. You give them a device as well as giving them some online access. I know Farhan, in Farhan's presentation, so I know from speaking with Farhan that his virtual reality pulmonary rehab is useful with patients that have not got internet access. So 30% of the patients that he uses that with, he gives them internet access by giving them a Wi-Fi dongle. So that to me shows me that there are patients out there that could use this technology if they had it, but because there are so many steps that a patient has to overcome before they get the internet at home, there's almost a need to figure out some way of supporting patients on this journey. There isn't a particular group of patients that don't have digital. There are non-digital patients within every segment of our patients. So there isn't a really super easy way of identifying even how big the problem is. You know, we almost need questions on the census to say, do you have the internet? Do you know how to use email? So that there's quite a big, it's a sticky problem and it's a big problem. We're working on some solutions, but it's not an easy one to fix. It's complicated.
Yeah, I mean, I think you're right a bit. Population digital literacy is a big challenge, but it can be overcome. Like, remember the Barclays Bank intervention with older people, which helped them with online banking. Something similar. It just seemed extraordinary that the healthcare sector hasn't taken that up now that we've gone digital, but maybe it will do.
And I think we're likely to see more closer collaboration between health and social care. So seeing it as being not just a digital thing, it's a whole social community.
It's a social movement. Yeah, community
social movement. Yes. And then if you were saying, when you were talking about the platform, what I was trying to get at with the thing about the passwords is that, so at the time when my patients were being given the MyCOPD license, it wasn't available as an app. It purely was an online thing. And so I personally think that the best format for this is putting it in a public domain so that patients, so as a GP, I'm spending all day long sending messages to patients nowadays using the messaging platform. So I can very easily send someone a link to the Active 10 app. They get it on their phone, they click it, they download it. They're not having to hand over any money or use a password. It just happens. And so it's that sort of technology I'd like us to be using more.
Yeah, I think you're right. Every step you put in to get access to something, whether it's a password or another click, means that a group of people will stop taking that next step. Somebody suggested putting it on YouTube, for example, as an easier way than having a password protected. I guess there's issues around costs and licensing fees, and MyCOPD want to make money out of their app rather than give it for nothing. A question for Rebecca, if I may. It was sent to me, but I'm going to deflect it to you, Rebecca, which is that given that it's very difficult to do 6-minute walk tests and shuttle tests now, what should our new standard exercise evaluation test be? I think you've mentioned sit-to-stand tests in your presentation. Do you think that's the one, or should we be doing something else?
We're using the 1-minute sit-to-stand test purely and simply because in a home environment it is easy. Most patients have a suitable chair to use. You can standardize it because you just make sure you use the same chair between the pre and post assessment test. It's not perfect. It is not great for demonstrating desaturation. So in those patients where we are concerned, where they're perhaps a bit borderline for LTOT or ambulatory oxygen, it's become quite tricky to figure out actually, are they suitable to exercise? And there have been some patients where I've said, well, come on, let's put some shoes on and let's go for a walk and monitor your oxygen levels and just walk down the street. But that's not a standardized outcome measure. I think the 1 minute sit to stand has been the best of a bad lot really for us. Certainly moving forward, our aim is that we will move back to running some kind of face-to-face clinic. If at the very least we're providing a walking test and a set of observations and then doing everything else as we have been.
Yeah, fair point. But so a work in progress. We're using something as an interim measure, but we don't feel satisfied that's the long-term solution to the problem. I agree with you.
Yeah.
And then Stewart, a question for you, which was, could we use the MyCOPD or the other links you've given us, or should we be using them to educate and train carers who go into people's homes to try and get them to do rehab with patients? So I'm sure you're aware, for example, of an initiative that occurred some time back where firemen who were going into older people's homes to check their smoke detectors actually also did a health questionnaire and checked the blood pressure of people, for example. Is that something we should be trying to do, trying to integrate this? You mentioned social care, rather than just see this as the as a healthcare specialist PR type of intervention?
Yeah, so I mean, we can all kind of think about how we use technology ourselves. So for example, we must have 30 cookery books at home, but frequently, if it's my task to make some food, I will look at the ingredients, I'll come up with a plan, and then I'll Google the recipe. I won't go to a cookery book. And the fact that I can find some great recipes online that aren't behind a paywall means that those are recipes that I'm using. There are some really good resources out there, things like the Carbs and Cows books and apps that are really good at communicating to patients stuff about healthy diet and calories in food and stuff like that. So there's something about being imaginative about how we get that education spreading around. I don't really mind what format it's in. I think the more our patients and carers understand about pulmonary rehab and the benefits of exercise, the better. So I'm not precious. I don't think this should just be something that only pulmonary rehab specialists talk about. I think there's a role of the pulmonary rehab specialist, and then there's something about like pulmonary rehab light, which is all the stuff about reminding people why they need to stay active and do the sorts of movements and take part in the sorts of activities that promote balance. You know, dancing is a really great exercise. You can put the radio on and have a go at doing a dance.
That's perfect. I'm so pleased to hear that. I've just taken up ballroom dancing, so that sounds ideal for me.
There's even myself. I'm just recovering from COVID, so I've recently had it, and I've recently had a dabble at downloading an online exercise platform. It's called Les Mills. You can delete that from this thing if you wish, but it costs about £9 a month when you've gone beyond the trial period. But there's a whole bunch of exercise videos there, dance classes that you can take part in from the comfort of your own home. And the fact I can do that on my TV in the lounge means it's entertaining. So I'm likely to do it. Whereas some of the pulmonary rehab stuff can be a bit dry.
Okay, that's an interesting challenge. Yeah.
So there's something about teaching patients these are the sorts of things that you need to do the dry kind of textbook pulmonary rehab bit. But then there's something about thinking when you've gone through the pulmonary rehab course, what do you do to make exercise fun? How do you make it as a sticky activity?
Okay, so Rebecca, can I put that to you then? So there'll be some here thinking who are PR purists who say, well, look, there's an evidence base behind PR that if you do this, this, and this, you'll get that kind of output. Whereas if you do general sort of whatever it is, exercise or dancing, whatever, it's good for you, we know that, but you're not going to get the same kind of outcomes that you would get from an organized, standardized pulmonary rehab program. What's your view? Do you think COVID has knocked us so much sideways that we just have to be pragmatic about things and do the best we can under the circumstances, or should we be trying to adhere as much as possible to the evidence base of pulmonary rehab and try to reconstitute that in a virtual form?
I think we absolutely need both. So historically, patients coming through pulmonary rehab predominantly have been those who have lost confidence with physical activity and exercise, and they tend to be the vast majority of the patients we see coming through the programme. But it's all well and good me getting them feeling a little bit fitter and a little bit stronger, but if they're then going to go and sit back and watch the telly all day, then there is absolutely no point in me doing my job. So absolutely, the role of pulmonary rehab for me personally is about promoting physical activity, promoting exercise, improving their exercise tolerance and improving their health. But actually, I have a huge role in promoting exercise and activity for fun and making sure that what they're going to continue to do once they have left my classes is going to be enjoyable, because that's the only way they're going to continue. And so certainly in a face-to-face group, we would spend a huge amount of time talking about what's available locally, check your local churches, have a look what dance groups are going on. There's a chair-based exercise group that meets here. You could try some Tai Chi, that meets here. I am quite lucky in that I have lived within an 8-mile radius of where I run rehab my entire life, so I know what's available locally. I can sit and say, oh, well, have you tried the Methodist church 2 miles away? Because they do a fantastic Tai Chi class. Or have you tried the brilliant yoga group? Or, oh, you really used to enjoy dancing. Have you thought about trying this? And really tailor where I'm directing patients to following pulmonary rehab. But equally, those patients who are quite confident about being active, then there's no reason why, if they are confident and feel happy to go for it, why they shouldn't go for it. They may need pulmonary rehab in the future, but they might actually be in a situation where they just don't. They might just need a little bit of education, and perhaps that's what we need to look at, because pulmonary rehab is not just about exercise. It is a small part of what we do. And that education aspect, perhaps we need to look about how do we give that, make that available to patients who perhaps don't need the exercise element of pulmonary rehab.
Yeah, I was very struck by that term, Stuart. You said making exercise fun, and I think that's a really important point for us. Again, sometimes we kind of over medicalize the model, thinking, okay, well, this is what the evidence base tells us to do, so we have to do a 6-minute walk test, we have to do a shuttle test, we have to put somebody on a treadmill, we have to put somebody on a bicycle. That's the only way to get the sort of standardized exercise that we need to do. But that's just so unreal for a lot of people, that when they leave that environment, how do they translate that into something which keeps the benefit of the pulmonary rehab program going? And you're absolutely right, perhaps introducing a dance class or a Tai Chi class into the middle of your pulmonary rehab program offers people that translational moment into, well, what does this really mean for me in the real world? Because I don't have an exercise bike at home and I don't have a treadmill. What am I going to do? And I know probably there are people already on the button now saying, well, I already do that. But I think that's a really interesting point. Can I just move the conversation slightly laterally but relevant, is to introduce the COVID. And I'm sorry to hear that you've had COVID, but so pleased you're well enough to be here today to talk about that. But that there are concerns, of course, that as Andrew Menzies Gow talked about, what's going to be the impact of whatever we want to call it, post-COVID syndrome, long COVID, whatever people are going to come up with the terminology in the end, on pulmonary rehabilitation. And as a general practitioner, are you getting patients coming to you with symptoms where you're thinking, aha, pulmonary rehab is the answer, or are you finding the patients you're getting have got such a complex syndrome that pulmonary rehab doesn't look like the answer to you?
So I'd say at this point, the north of England, we weren't hit so bad in the first wave, but so my own practice, we've only really been hit big time in the second wave. So that's quite weird. That may seem quite weird. So my working knowledge of COVID I've really only experienced it firsthand in the past couple of months. So I have patients where I'm thinking this sounds like a post-COVID kind of collection of symptoms, but they're not so severe at the moment where we have to think about referring them on to a clinic. I'm just giving them the general information and the NHS website that tells them about the sorts of things to expect. And the thing about, from talking with pulmonary rehab physio type people and friends, I know what the sorts of things that they've been recommending. The thing about not pushing it, taking it easy. So it's just, we're just in the kind of general advice kind of phase. I think there'll be other, at the moment we don't know what proportion of our patients will need the more specialist rehab services. I'm sure we will have some of those patients, but it's not clear at the moment what those numbers would be like, to be honest.
Okay, that's helpful and an honest answer, as you say, but I think it is going to be a challenge. What about Rebecca, in your service? Are you getting post-COVID patients referred to you at the moment for virtual rehab?
Not yet. So in Nottingham, the post-COVID, the long COVID type patients who are struggling still are predominantly being seen by the acute trust. We are looking at what services we can provide moving forward in the community. I don't think it's going to be a case of, well, you've got long COVID, therefore pulmonary rehab's the answer. I think it's going to be far more, well, these are the services we have available, which is going to suit you best because of the variety of symptoms that we're seeing with COVID. It might be that they'd be better sitting in a pain clinic. It might be that they'd sit better looking at sort of a chronic fatigue kind of clinic. It might be that actually if they're just really breathless and need a lot of rehab, then absolutely pulmonary rehab is probably where they need to be. I think the tricky bit is going to be is that a one size fits all is not going to work, and that we're going to have to perhaps be a bit more flexible about how we work and look at, rather than saying, well, this is the service I'm commissioned to provide and that doesn't include X, Y, and Z, so you can't come. It's going to be about saying, well, actually, I can see why they've referred you through to me. I'll take the referral, or saying, well, actually, you know what, I've had a read through your referral. I think this team would suit you better, and making sure we're really careful and clever about that signposting so that patients are getting the right treatment at the right time.
Okay, well, that's interesting that both of you have that experience down in the southeast, where wave 2 is really getting to grips at the moment, but wave 1 was quite severe, where we've got quite a lot of post-COVID syndrome patients. In a lot of places, just by default, the respiratory physicians have taken on the role. In other places, it's intensive care. But if you haven't been to hospital with your COVID and you're a community-based patient, it can be quite difficult to find a service that's prepared to look after you. And whilst I think every integrated care system has now been asked to come up with a regional type of long COVID service, I'm not sure that every region's got them operating yet. So you may find that pulmonary rehab will be the first port of call for a lot of the patients. And then, as you've rightly pointed out, we'll have to think about how do we manage the multiple systems that are affected by COVID, which aren't just going to be respiratory symptoms for patients. Okay, well, that's interesting too. So we're drawing to a close. I'm going to ask each of you, if you might just think for a moment, what's your advice to those out there managing pulmonary rehab in this very difficult time? You know, what would you advise them to do for the next few months that would make most benefit to patients who normally would be going through a face-to-face conventional rehab program? What can they do to give best outcomes for their patients? And before, I'll go to you, Stewart, first, and then to you, Rebecca. But before you answer, somebody put in the chat about my COPD that in their community team, which I think is based in Essex, so 3 cheers for Essex, they have a coordinator who supports the patients with issues like log on and forgotten passwords and that kind of thing to try and help them. So somebody who's on the end of a phone who can respond to those things, and that might be something that might help. So Stewart first, and then Rebecca, maybe 2 minutes on what's the best thing that people can do to try and help patients in this very difficult time? What's your advice to them? And then to you, Rebecca.
find out what the patient wants to do from the point of view of exercise. Find out what they're doing already, and find out what they're interested in doing. And sometimes really simple suggestions, like if a person feels less confident when they're having a walk because of balance issues, something simple like advising them to wear trainers, or making sure they've got good grippy shoes can make a big difference. Walking is a free exercise. Reminding patients that the risk of catching COVID if you're out walking is really quite low.
Yeah.
So encouraging people to get out there, even if it looks like it's raining. It's never quite as bad when you're out there as it looks when you're inside looking out. So it doesn't really matter what you do, as long as you do some kind of exercise. Really, a big thing I'd like people to do would be to talk to their relatives and their friends, and to try and encourage the people who are not digital to take up the offer of making more use of digital, because this is so important for accessing health, primary care, secondary care. You know, in our region in Lancashire, we had a lot of appointments at secondary care taking place by video. You can only do that if the patient knows how to use video.
Sure.
So there's something about getting families and friends talking to one another and figuring out how they can help people to get online, and to remember the savings that you can make. You know, I've recently switched energy supplier, saved me £200 a year. I can only do that because I know how to use the internet.
Yeah, fabulous, thanks. That sounds like a great advert. Rebecca, what's your advice for top tips from you?
I'd very much going to mirror Stewart, really. It's about getting to know your patients and really finding out what their problems are, and tailoring what you're providing to their needs. We're in quite a luxurious position in pulmonary rehab at the moment, in that we are not having to try and treat 5, 10, 20 patients all at once. You know, when we have that one patient in front of us, we have just got to deal with that one patient. We're not looking to make sure that nobody's doing something too crazy with the hand weights. So make the most of that time, really sit and have a chat with them and find out what their needs are and how you're going to meet them, and tailor make your treatment to them. And give it a go, because ultimately if that patient's sat doing nothing, then whatever we ask them to do, whatever we get them doing, however we get them moving, is better than sitting doing nothing.
I think that's really helpful, sound advice. Start with our patients. Let's find out what they want and give them choice. As Andrew Menzies Gow said at the beginning, we've got to remember that we don't want to increase inequalities in healthcare by having a purely digital approach to people who aren't capable. Stuart's reminded us of the fact that we need to try and get people digitally enabled, because the future is digital. I think that's true, and whatever we go back to, it's not going to be the same. And digital is always going to be a fact of life now for healthcare and social care and life in general, whether it's supermarket shopping or whatever. And the final just reality check from me is that in London, of all the non-face-to-face consultations that took place in the first 6 months of the COVID pandemic, 80% of them were telephone consultations. So let's not forget simple things like picking up a phone, as Rebecca has mentioned, and keeping in touch with our patients that way. We don't have always to go for the most complex tech. So thank you, Stewart. Thank you, Rebecca. Thank you, Mukesh and Claire, for trying to join us. And we look forward to seeing your PowerPoint and your presentation shortly. Thank you for the organisers of putting this event together, and thank you for bearing with us through the technical problems. We finished exactly on time. Let's go out there and do the best we can for our patients, because that's what we all want to do ultimately. Thanks ever so much, everybody. Take care.
Thank you.
Be safe.
Thanks a lot.